Welcome to the HQO webinar on conducting individualized care plans. This is the second in a series of webinars presented by HQO to the HealthLinks community. The first in the series was presented on November 13th, and this was on HQO's quality improvement framework and some of the HQO resources that are available. Today we've got approximately 137 registrants for this webinar. And just for your interest, 80 of them are directly connected with a health link. 27 registered from primary care, 16 from hospitals, 22 from LHINs, 35 from community services, and 3 from long-term care. So welcome, everybody. Just a little housekeeping note to begin. My name's Julie, and I'm going to be moderating this session. And I'll walk you through a couple of tips to help you during the webinar. If you happen to attend on November 13th, my apologies that we'll have to repeat a little bit of this information, but you can just get settled while we talk through some of these things. So I've just highlighted at the orange arrow on your dialog, so it should be on your dialog box, and that will open and close your control panel. You might want to give that a try while I'm speaking just to play with it a bit. The next thing I've highlighted is the audio panel, and this provides some useful information. By default, you've joined the webinar via mic and speakers, and everyone has been placed on mute just to maintain some good sound quality. If you prefer, you can join us by phone by clicking on the Use Telephone link. If you have bandwidth concerns in your area or you have spotty internet access, it might be best to quickly change listening modes by doing Use Telephone. The other important part in that control box is the question box. During the presentation, you have the ability to send questions to our webinar staff, myself, as well as another moderator through the questions pane. Simply type in your question and hit send. At the end of the presentation, we will have some time so that you can ask questions to the guest speakers. And again, we will be doing this through the online chat box rather than phone and voice. Today's webinar is being recorded and will be shared on the HQO website within the weeks to come. Just to note that virtual learning provides opportunities and drawbacks, and you may wish to close other distracting things on your screen just so you have a chance to focus on this presentation. The presenters today are Tracy Housen from HQO, Dr. Jocelyn Charles, and Dr. Kaplan. And there is no commercial support for this and no conflict of interest to disclose. Now I'm going to pass the baton over to Tracy Housen, our first speaker from HQO.
And thank you, Julie. HQO has developed 3 evidence-supported improvement packages that outline change concepts that support the triple aim and align with the Health Minister's Action Plan, the right care in the right place at the right time. These 3 bundles are chronic disease management supporting health independence and transitions to care. These improvement packages were created in collaboration with Ontario health care organizations, leading practitioners, and researchers for use within HealthLinks. For an overview of the 3 improvement packages and a better understanding of Health Quality Ontario's improvement framework, we encourage you to go to the HQO website. But after this webinar, the link to the HQO website will be shown at the end of this webinar. I will also mention that the introductory webinar, an overview of the HQO Quality Improvement Framework and HQO resources were broadcast on November 13th and will be available at the HQO website by the end of this week, November 29th. This series of webinars are focused on Transitions of Care Improvement Package. And why begin with transitions? By focusing on transitions, we can simultaneously address multiple issues around inefficiency and fragmentation and move towards more integrated care. A care transition describes the transfer of a patient between different settings and healthcare providers during a course of an acute or chronic illness. As the population ages, healthcare systems are challenged to respond to the needs of an increasingly older patient who are affected by multiple chronic conditions and who require a combination of regular primary care support with intermittent or regular specialist care. This diagram illustrates what literature shows around best practices and transitions to care being dependent upon 4 change concepts: health literacy, health assessment and follow-up care planning, medication reconciliation, and for this webinar, individualized care planning. All these change concepts in the transition package are interrelated and should be considered a bundle. For example, strengthening health literacy means that we help the person to develop the knowledge and skills required to independently manage their care and home environment. Risk assessment and follow-up care planning mean that we stratify those at greatest risk for readmission to provide them with a different level of care planning, one that involves earlier and closer follow-up after discharge. Medication reconciliation is a formal process where healthcare providers partner with patients to ensure accurate and complete medication information is communicated consistently and at transitions in care. And individualized care and discharge planning, which is the topic for today's webinar. The other three change concepts will be addressed at webinars over the next month. Our agenda today is on individualized care and discharge planning. So what is it, and what are the elements? And we're very excited to hear from Dr. Charles and Kaplan on their experience in the care coordination tool, to share a few resources, and to raise the challenge to you on what can you do by next Tuesday. When there is poor coordination of care across settings, patients and their families are confused and uncertain about key elements of their care. Patients discharged from hospital may find themselves back in the emergency department or suffering at home, situations that may have been avoidable. Most of us have either witnessed or experienced poor care coordination or planning for care. Systems of poor care coordination include unclear or delayed discharge instructions, conflicting plans and instructions from different care providers, and medication errors, including dangerous drug interactions or duplications. Delivering high-quality, patient-centered health care requires crucial contributions from many clinicians and staff across the continuum of health care, including the effective coordination of transitions between providers and care settings. It also requires an openness on the part of the care practitioners to establish relationships with patients and families, moving from didactic experiences to two-way communication, collaboration, and partnership with patient, family, and caregivers. Collaboration requires, in addition to having expert clinical knowledge and skills, the healthcare practitioner being comfortable and skilled in dialogue, reflecting back, active listening, and reframing with the patient, just to name a few. Working to reduce avoidable rehospitalizations is one tangible step towards dramatic improvement of healthcare quality and the experience for our patients and families over time. High-quality, patient-centered care should support patients through this stressful time while maintaining the patient's honor, self-worth, and dignity, other crucial aspects in good healthcare. We know this has to be addressed, and to that end, today, in this webinar, we are focusing on one aspect of improving care planning. We will be focusing on transitions, primarily from hospital to home. In addition to the HQO Transition and Care Improvement Packages, which we hope that you've all had the opportunity to peruse, there are recent discharge planning best practices. These are founded in large part on the Ontario Health Technology Advisory Committee that I refer to as OTAC, and this report of April of this year, 2013 recommendations. And these address the continuity of care. These recommendations are the result of an extensive review of literature and consultation with expert patients. The literature points to 3 key points in the continuum of care where each of the 9 best practices should be applied. So the three best practices are the Category 1 being pre-discharge practices, Category 2, discharge planning processes, and Category 3, assessment for post-transition risk and activation of post-discharge follow-up. We're going to drill a little bit deeper in each one of these. In Category 1, the pre-discharge practices include pre-discharge planning incorporated as a standard care for complex patients admitted to hospital, with patients and caregivers being involved as partners in the discharge planning process, and individualized comprehensive assessments and care plans being developed. Category 2 includes individualized discharge plans being developed on admission for patients with complex needs, where protocols are established to ensure medication reconciliation at key transition points, and for families and caregivers being provided with information and resources to support their transition. And finally, Category 3 being the assessment for post-transition risk and activation of post-discharge follow-up, which includes standardized risk assessment tools being used, where the appointments are booked with the patient's primary care provider, and where complex patients receive a follow-up phone call within 48 hours of discharge from hospital. There are two additional system-wide goals associated with OTAC recommendations, and they are the adoption of a standardized discharge summary template for use among all healthcare organizations that perform discharge planning, and system-wide implementation of designated supports for complex patients in the post-transition follow-up period. I suspect many of you on today's webinar are familiar with some of the provincial activity in support of coordinated care planning. Care coordination requires a patient-centered approach, that care providers are working together, and the ability to share information across the continuum. And as we know, the priorities for HealthLinks in the first year are ensuring that seniors and those with complex illnesses have timely access to a primary care practitioner, in improving the experience of the care for those with complex illnesses, and development of coordinated plans of care for the top 5 to 10% of Ontarians with complex chronic illnesses. Health Quality Ontario is partnering with the eHealth Liaison and Special Projects Branch of the Ministry of Health and Long-Term Care to develop electronic supports to share patient-centered plans of care with the Circle of Care, plans of care that are developed with the patient and the family in collaboration with the care team. While the electronic supports are probably about a year away, clinicians from across the province have been meeting regularly to identify the key elements of a patient-centered plan of care and to construct a template of what that integrated plan of care could look like. Clinicians from across Ontario, from acute care, primary care, CCAC, and community support services have told us that the following elements are critical to care coordination. The data quality and standardization are important, but need to be balanced with flexibility in sharing complex information. That the coordinated care plan should use plain but precise language, and that the information needs to be comprehensive while only presenting the minimum amounts necessary to make a good decision. Social supports and determinants of health are important. And last but definitely not least, clinicians across Ontario have told us that patient-driven elements of the coordinated care plan are critically important to get right and to be prioritized. They predict that the future of coordinated care planning will look less like the medical models of the past and more patient-centered, with headings like My Plan of Care, with elements like What is most important to me right now. Two of the clinicians who have been leading the care coordination work at HealthLinks and their LINs, and at the provincial level, are Dr. Jocelyn Charles and Dr. David Kaplan. We look forward to hearing from them about their experiences improving the coordination of care for seniors and those with complex illnesses. But before I introduce them, Julie, can you remind our participants about how they can join in the conversation?
Sure, Tracy. So by using the question box over on the right-hand side of your screen, if you type your question in, we will respond. If you'd like it to be a more of a private question, you can just indicate that you would like it privately responded to, and we will respond over the chat, over the question box. but most of the time we will be responding to all or providing the question to Drs. Charles and Kaplan.
Thank you, Julie. We are thrilled, very pleased to have with us today Dr. Jocelyn Charles and Dr. David Kaplan, who will be sharing their experience with us on the improvement of the coordination of care for seniors and those with complex illnesses. Dr. Jocelyn Charles is Chief of the Department of Family and Community Medicine and Medical Director of the Veterans Center at Sunnybrook Health Science Center. She is an Associate Professor in the Department of Family and Community Medicine at the University of Toronto. Dr. Charles has provided primary care in the family practice unit at Sunnybrook, including house calls to her local homebound patients for over 20 years. Her clinical and academic work has been focused on older patients with complex chronic disease and developing models of care to meet the needs of these patients, both in the community and in long-term care. With her today is Dr. David Kaplan. Dr. Kaplan received his MD from the University of Toronto in 2001. Prior to his medical training, he completed his graduate work in the Department of Health Policy Management and Evaluation and the Joint Center for Bioethics in the Faculty of Medicine. After completing his residency in Family and Community Medicine at North York General, he joined the staff of the Department of Family and Community Medicine as assistant professor with a member of the Joint Center for Bioethics. David has taught extensively in the pre-clerkship, clerkship, and postgraduate programs. He co-led the development of the largest family health team in Toronto. From 2005 to 2013, David served as the chair of the Research Ethics Board at North York General. He was family physician-in-chief, interim, and medical program director in North York General from 2006 to 2008. David is currently the primary care physician, LIN lead for the General Local Health Integration Network. His current quality improvement and research interests include primary care engagement and health links, facilitating physician knowledge transfer through the point-of-care EMR tools, and developing and measuring the impact of e-health solutions on health and patient care. He is currently leading a project that hopes to design and implement a primary care and patient-designed e-referral infrastructure between the 4 major electronic health record vendors in North Toronto. And now getting to what most of you are probably on the line to hear, Dr. Charles and Dr. Kaplan, please take it away. I understand Dr. Charles will be speaking first. And I will forward your slides, Dr. Charles. Dr. Charles, are you on the line?
Dr. Charles, you may have your phone muted still.
We'll hopefully connect in this shortly here. Apologize, folks. We will hopefully be with you shortly. We seem to have lost connection with Dr. Charles. We were actually speaking earlier, so we know we have connections.
Hello.
Oh, here we go. Hello there. Welcome.
There, we're going to use my laptop, so hold on. I'm just going to switch it to Dr.
Round of applause. I can hear it there and here as well. Awesome.
Sorry about that. I was speaking to a phone that wasn't responding.
No problem.
Good afternoon. What I wanted to start with is, I'm trying to adjust. Are you adjusting my slides? I just need to. Thank you. My disclosure is that I have no conflicts of interest. I do all of this work for free. Next slide. So I wanted to start with, as we start down the journey of coordinating care better, we have to start with, well, who are we coordinating care for? So I wanted to do talk a little bit about how we define complex patients, and then talk about what is care coordination, why it's important. We did just hear why it's important, but a little bit more around that, and why it's become so difficult in primary care. And tell you a little bit about the journey of developing the coordinated care plan template, and then some discussion around, well, how do we actually coordinate providers to do this? So next slide. So who are the complex patients? Who are we talking about? Who are the patients in the top 1% and 5% of healthcare utilization? I'm going to tell you this is my own definition after all the chart reviews and discussions that I've had through this journey. So really it's a patients with multiple chronic conditions who also have what I'm terming a complexity factor, because what we're realizing it's actually just not about medical complexity. So this is really an added health condition or situation that together with the person's chronic condition it really increases the need for coordination efforts so that they can have timely, accessible, and effective care. And so some of the examples that we've seen in our chart reviews is someone who may have an unstable mental health condition. They may have new or worsening cognitive impairment or dementia. I think the really key point here is in the integration of the determinants of health into what we are terming health conditions, that we're not just talking about medical conditions here. I think the whole art of care coordination needs to fully incorporate that. So when there's a determinant of health deficiency, such a problem with housing, access to appropriate food, safety, social supports, and health literacy, these significantly impact the ability to provide coordinated care. And then other difficulties accessing needed care and services. So sometimes this is language, culture, mobility, etc. So next slide. So I thought we'd start with, when we talk a lot about care coordination, but when I talk to primary care providers, they say, well, what do you mean? Aren't we coordinating care now? Because in their own setting, they are, but I guess it's really focusing on the deliberate organization of patient care between providers, including the patients, that helps facilitate the delivery of health care. And right now, we know that for the most part, the people who are coordinating care in our healthcare system are patients and their families. Some want to do that. And getting a little bit, just building on what was talked about earlier about why is this so important. It's not just about inconvenience to patients, that this is frustrating for both patients, their families, and providers, but these errors in transition lead to significant patient harm. So we've heard about medication errors. We know, those of us who work in acute care, we see preventable readmissions, and we see preventable emergency room visits when people can't access the care they need, when they need it, and where they need it. And we've sometimes forget about the unnecessary pain and suffering that we put people through because of unnecessary procedures. An admission to hospital is not without discomfort and potential loss of function and decline. In addition, premature institutionalization. I have been involved in the long-term care sector for almost 24 years, and I repeatedly see people who are admitted to long-term care who don't need to be. If they only had the right services in the community, then they could remain there. And unfortunately, transition errors also lead to premature death. So there's not only these incidents of harm, but there's also lost opportunities for patients to achieve better health outcomes. The next slide. So why is this so hard? When I first started in practice, this was not so difficult. I mean, I did a fellowship in care of the elderly back in 1989, and this was not nearly so difficult as it is now. But I think many things have changed. One is that people are obviously living longer. We're getting better at treating chronic disease, so people are living longer with chronic disease, and rarely do people have one. They have usually multiple. And we're trying to provide care that is more and more complex with shorter time frames. We know in the acute care sector, there's a big push to shorten length of stay, And so we're asking people to do a lot more difficult work in a shorter time frame, and often with very limited human and financial resources. Then we have our multiple specialists who are doing great care for single diseases. And we know that evidence-based care for one disease often conflicts with evidence-based care for another disease. So if you actually do evidence-based care for some of these people with multiple chronic conditions, you will cause harm and possibly death to them. So we need to have models that really look at ways to integrate evidence-based care for multiple conditions. And then we throw all of this into the single provider serial consultation model, where we have office visits scheduled based on an old fee-for-service remuneration model. So the thing you hear is the patients say, my doctor sees me for 10 or 15 minutes and will only deal with one problem. Well, if you take one of these complex patients and deal with one problem, that's like touching the first domino, and the others will go. So you cannot deal with one problem at a time. Next slide.
Dr. Charles, I wonder if you can increase your volume on your phone.
We'll make it closer.
Is that better?
Oh, yeah.
Thank you.
I'm sorry. So one of the knee-jerk reactions that I watch happen around me is that when care becomes more complex, people consult more people. And the more people that are consulted, more physicians involved in a patient's care actually increases the patient self-reports of poor care coordination. And we know this from the Commonwealth Fund survey. So the reported errors actually double as the number of physicians involved in a patient's care double. And I have patients who have probably 6, 7 physicians involved in their care. So next slide. So another reason that care is not coordinated was discussed earlier. There's no standard requirement for not only the content, so the standardized template is great, but also the timing of completion, and the timing that the family doctor actually can see it. So it's not about when it's completed necessarily. It's, you know, if it then gets put in the mail and it's sent to maybe the wrong address. So one of the things that we've looked at Sunnybrook is, do we have the right family physician's name, address, and contact information in order to be able to send a discharge summary to the right place? And then we have issues with communications at transitions of care. It's not standard practice to have to phone when a patient and give the history when a patient is going to emerge. They just get sent. And the other issue is, of course, we have multiple medical records, some of which are just electronic repositories of the old paper charts. And of course, we know these don't communicate with each other. So who are the patients who are most at risk? Well, these, according to the literature, are patients with newly diagnosed conditions. And as I said, the people with multiple chronic conditions, because oftentimes they come into hospital for exacerbation of one of their chronic conditions, but the other chronic conditions are not necessarily addressed. So one chronic condition is tweaked, but then the impact of that tweaking on the other chronic diseases is not addressed. And then obviously, as we've talked about, transition points are a key crack in the system where patients fall through. Next slide. So we end up with this vicious cycle where we've got patients with increasing complexity of their care needs. We increase the number of providers because the care is so complex we can't possibly do it on our own. And then we increase the number of errors because no one's accountable for coordinating the care. So one of the key points in all of this care coordination is knowing who's accountable and who we assign with that accountability. Next slide. And through our journey of creating this care coordination tool, we have involved our patient advisory council here in the Northeast Toronto HealthLink. And I have attended the council and listened to those patients, and I've listened to many patients in my practice, and they keep telling me, I go to all of these different appointments, and I see this physician for this part, I see this nurse, and they're dealing one disease at a time, and eventually the patients say, I'm too tired to keep doing this. And next slide. And in addition to them having to physically go to all these different places using their valuable energy just to get to appointments, they then are asked to tell their story over and over and over again. Because quite frankly, we're just too busy to talk to each other. That's what they tell us. Next slide. So our experience in primary care is one of feeling completely overwhelmed. Our very complex patient comes in, usually booked for a short appointment, and we're trying to pull all of these specialist reports, discharge summaries together. The patient's waiting often because even though we've tried to read them before their visit, that's not always possible. And they're thinking and sometimes saying, don't you guys talk to each other? Like, why can't you just pick up the phone? And we can pick up the phone, but then there are challenges with reaching the person on the other end. So it's frustrating from both points of view. So next slide. So why don't we talk to each other? Why don't we communicate? Well, for one thing, I don't always know who's in the circle of care. I don't even know who I'm supposed to be calling. And I don't know who's responsible for communicating with who. I also don't know how to reach them. And what we hear from the literature and from family physicians is I've been trying to get family physicians to call the emergency department and give a history when they're sending a patient in. But what they say is, I've tried that and they're too busy to come to the phone or it's shift change. So the family physicians say, I've just stopped trying. Then I've talked to specialists, and this is verified in the literature as well, and they say, do you know how hard it is to reach a family doctor? They don't answer the phone. They're not using secure email. I don't know the back phone line. So they stop trying. And then what we hear from EMS is if there's a long wait time in Emerge, they can't wait to give a full narrative handover. I mean, they give their handover, but they don't have time to really ensure that everything's understood and what the patient needs and what is important to the patient is heard. Next slide. So what we know from the literature then is we need to make sure our coordination efforts are patient-centered. They must reflect the individual patient goals. They need to involve the whole multi-professional team. Everybody needs to know who's on first, who's doing what, and how do I reach them, and how do I reach them easily. And then we need to have information technology that's accessible and integrated across sites. And so what I keep getting told is, oh, just go to this website or that website and you can access it. Well, on one screen to have a patient's chart open and to be going to all these different websites takes up most of the visit. So then I'm spending less time with the patient. And then we have to do a paradigm shift from a dependent patient population who comes to us for help to us advising them with them having the right self-management tools to help with their own care. So just going to talk a little bit about, next slide, the journey through developing a coordinated care plan toolkit. I was asked by the Toronto Central LHIN to lead this project within our LHIN, and I thought, oh sure, I know all about care coordination. Well, what a wake-up call I've had. So I thought, well, first we need to listen this afternoon in May, and we had 40 participants. We had a complex patient and his wife, and we had the mother of a very complex child, and then we had providers from all sectors of the healthcare system. And we had a wonderful retreat. Lisa Priest interviewed in front of the group, the patient and the family caregivers, and then we brainstormed and really worked hard about what would a coordinated care plan toolkit look like. Then we developed from there a working group who had content expertise. So they knew all about the diseases that we were trying to coordinate care for. And we realized in doing that we ended up into this very deep pit of many, many toolkits for many, many different diseases. And I was told by a very astute colleague, Jocelyn, what you're trying to do is an entire PhD thesis. You need to back up. So we backed up and we established a smaller working group who had actual on-the-ground experience with truly coordinated care expertise. And this was people with experience through the impact model, which I'll tell you a little bit about, and the Integrated Client Care Program in the Toronto Central CCAC. We also very much engaged our Patient Advisory Council. They did brainstorming sessions of what a coordinated care plan would look like, and what they wanted front and center was their voice heard. They wanted it from their perspective. And so we landed eventually on, and now on version 12 of our coordinated care plan summary template, which is available to anybody who wants it. It is a PDF fillable, and it's told all through the eyes of the patient. We have also been using all of our work in working with the Ministry of Health group that was mentioned and sharing all of what we've learned. And we fully support that initiative, and it is ongoing. Next slide. So this is what we heard from our retreat and from just observations from the field. And I don't think I'm saying anything that anyone hasn't heard before. Providers are not approachable. We're not accessible. There's lack of clarity about what we can do. There's a communication issue I've already talked about. No one knows who's doing what. Availability of resources. And then patients are saying what they can expect is unclear to them as well. Families would like flexibility in their role in care coordination. And then the whole issue of, next slide. So the guiding principles we came up with were that, as I said, it needs to be person-centered, goal-directed. The key here is you can develop the most beautiful coordinated care plan, and it can be out of date in less than 24 hours. So it absolutely has to be flexible and responsive to change. It needs to, as I mentioned, promote self-management. And I think a key piece here as we move forward with coordinating care is we must ensure that it's built on existing resources and strategies. We have everything available. What we have to change is how we work with each other. And then the whole point about clear expectations and accountabilities is key, and I won't belabor the technology piece. It's an absolutely fundamental. Next slide. So we need real-time communication between primary care specialists and community providers at all points. Self-management, education and skill development for patients, and shared accountability for not only transitional care, but anticipation of possible care needs, and how do we plan for that. Next slide. So, as I mentioned, we do have version 11, but version 12 is coming. The only change is that I changed the, we realized in filling out the medication section there wasn't enough space in the dose column, so we're just tweaking some formatting. But the key highlights are that, as I said, it's from the patient's perspective. It's all using common language that a patient can understand. The health conditions are not just COPD, CHF. They include insufficient housing, safety risks, access to food. Everything's included. It's anything related to the health of the person is included in the health conditions. And resuscitation decisions have been moved into goals of care. They are actually not part of advanced care planning, and I'll get into that in a minute. And then, as I mentioned, we've helped to inform the ministry work around the coordinated care plan, and we hope to be involved in piloting a paper version of that. And hopefully we can look forward to an electronic version in the next year. Next slide. So something very interesting happened in the past month. Doreen Ouellette, who's leading the East Toronto Health Link in developing the advanced care planning section of the coordinated care plan, called me up and said, Jocelyn, can I meet with you because I need to talk to you about something. And she said that, you know, the group looking at advanced care planning is struggling because really, when you talk about resuscitation and prolonging life, that actually goes in the care goals, not advanced care, because these are expected things that can happen when someone has complex chronic disease. And the other key piece was that patients don't know what we're talking about when we talk about CPR and DNR. They think DNR is do not respond to me. We need plain language. Next slide. So we involved Bob Park, who's an ethicist at Humber, and Blair Henry, who's an ethicist here at Sunnybrook, and Doreen Ouellette. And we brainstormed and came up with these revised questions, which I just love. When my heart and or breathing stops, if someone is close by, because they don't know what witnessed means, I would want them to try and restart my heart and or breathing, or I would not want them to do so. And the other one, if my condition gets worse and it looks like I might not survive, I would like to be offered all investigations or treatments deemed reasonable to prolong my life, or I would only like that would focus on comfort. And I think this is a real step forward. It's in plain language. It's in the right section of the care plan. So the next part, the next slide, the hard part begins. How do we actually coordinate providers? How do we build more collaborative ways of working together? How do we create better linkages between primary care and specialists? How do we create the old doctor's lounge where you could just walk in and get advice? The patient never had to go anywhere. How do we build better linkages between primary care providers and community care? And how do we build relationships between providers who are already involved in a patient's care? And I think we need to explore ways to develop shared care models for complex patients. And you all on this teleconference or webinar probably have a million ideas, and we need to hear them, because I think within our collective we have the wisdom to figure this out. Next slide. So just tell you a little bit about our Impact Plus. This is a model that was developed in 2008 at Sunnybrook, the Interprofessional Management and Practice of Aging and Complex Treatments plus Specialists. And this started, the idea for this started one Friday afternoon when a colleague, Dr. Ross Upshur, and I had just finished a very busy clinic with very complex patients. And we both said to each other, there's got to be a better way to do this. And we thought, what about if we could have a longer appointment and have all the people in the circle of care there with us, with the patient, to have a visit to sort out all their problems. Next slide. So the birth of this was an interprofessional care and education grant. So the patient comes and they are in one of our clinic rooms with their care provider, and our family medicine resident goes in for 20 minutes and unpacks all of their concerns. The whole interprofessional team is there watching on the camera. The patient is aware of this, and then they brainstorm and whiteboard what they've heard. The family physician, who's known the patient usually for years, is there to give the narrative, and then we bring to the patient what we feel is a good care plan based on what they've heard. Next slide. Quick picture of what impact looks like. So you can see the team is watching, and then different team members will go in and assess, and it's a wonderful brainstorming session with the patient. Next slide. But the best experience I've had to date was we wanted to try to do this with one of our community physicians, community patient, who is a very complex patient, and the caregiver. So we couldn't quite figure it out, so we had the patient, the husband, and the daughter come to Sunnybrook, and we had the community family doc come and the community pharmacist come, and we had our geriatrician, Dr. Marie Norris. We had the patient's CCAC care coordinator. I facilitated. And for 2 hours, we started with what was most important to the patient. She said she wanted to laugh more. She was is a very complex patient. And we tried to just work on how we can improve her quality of life. And at the end of the session, the family doctor said that was the best 2 hours I've spent. The family we felt heard. We've been given ideas we never thought were possible. And so it was a very positive experience. Next slide. So the final slide is the key to coordination is moving from our current multidisciplinary model where everyone just does what's in their scope of practice, nothing more. We don't talk to each other, to that's not always, but for the most part that tends to be what happens, to an interprofessional model of care where we're all responsible for combining our knowledge and skills to meet the patient's goals both within and across settings. So we need a common platform of how are we going to talk to each other. So I'll pass it on to David.
Thank you, David, and I feel is going to bring up your slides.
Great. Okay, so you can bring up the next slide, please. Everybody can hear me all right, I hope? So next slide.
We can, thank you.
Okay. Perfect. Okay, so I'm going to really briefly talk about our process of care development plan, which was a little different because it was sort of pan-LIN. And then I'm going to talk about challenges of coordinated care plans and some mitigation of these challenges, especially with community physicians. So next slide, please. So this is my favorite building in New York City. This is the Flatiron Building, and the reason I show it here is actually because of a quote of the architect who designed it, which was Burnham. And Burnham says, "Make no little plans, for they don't have the magic to stir men's blood, and probably will themselves not be realized. Make big plans, aim high, and hope and work." And that was really the task that I was given to lead in the Central Inn, which is not just to coordinate between a care plan development for one health link, but to try to create something that we could use across all of our health links in the Central Inn. So just next slide. So we really did a ongoing development of a coordinated care plan between April and October of this year. We started a little different. I'm going to walk through it quite quickly, but we started with our primary care network, which is a network of network model where we have a table that meets about every 6 weeks of primary care providers in the Central Inn. And I posed it to them about what should a care plan look like that was really going to be friendly both to the patient and to the primary care provider, because it's all about, in my mind, engagement of primary care. And what they felt was that they were going to we should start with something called the cumulative patient profile and really just add advanced directives to it. And so we brought that to our LIN system planning table, and we had some feedback from our HealthLink care coordinators with some of our early HealthLink patients, and showed a draft to the ministry and showed a draft to Jocelyn's group. And then we did some patient engagement, or I should say our HealthLinks did some patient engagement. The HealthLink up at the north part of our LIN actually ran an experience-based design focus group with patients to assist with co-design and highlight what the patient goals were. We took those that feedback, worked it back into the care plan, and then had a dialogue with our larger primary care network group once again. Shared that with them, really focused on clinically relevant information and patient goals, and then asked them, because of the network and network model, to share this idea of being able to see a request for information for a common care plan with the local family physicians in their areas, because obviously in order to fill out these common care plans, we need data, and a lot of that data exists in the primary care record. And then practically, our final version of the care plan was shared with the ministry and with the Northeast Toronto HealthLink, and the Central Inn has decided to use the ministry coordinated care plan template, which is being piloted in 2014. So there's consistency in the system. So we decided that it's more important for us all to use the same template than it is for us to feel like we wordsmith the template that we're using. And we felt that a lot of the work that we have done over the last 6 to 8 months has really influenced, as I know Jocelyn's work has done, has influenced the care plan development provincially. So if you go to my next slide, I'm going to talk about now practically what are the challenges to coordinating care plans. And if you go to my next slide, you'll see I've split them. Well, I highlighted one thing, and this is based on some old ISIS data, but basically this really highlights the fact that so much of the healthcare in the province actually takes place in the community, and specifically in the primary care office. So every day in Ontario, there's about 2,500 times more primary care visits than there are hip and knee replacements. And just goes to show you how much interaction our patients have with the health system outside of the hospital and in their family doctor's office. So if you go to my next slide. What I've done is I've sort of broken up the challenges of trying to coordinate coordinated care plans and care plan discussions between knowledge and communication. The first thing is that a lot of primary care providers and specialists don't even know that their patient's been admitted to the hospital. So we need some sort of form of ED notification. I'm going to give you a really brief example. I had a patient of mine who was actually being treated actively here at Sunnybrook for cancer therapy at the Odette Cancer Center. And he deteriorated at home, and his family took him to North York General, which is where I'm on staff, and he got admitted. And astutely, my colleague in general internal medicine called my office because he really didn't know what the plan of this patient was vis-a-vis their cancer. And in fact, this patient had had a discussion with his oncologist about 6 days earlier that there really wasn't any more active therapy that could be offered. And as opposed to working up this patient's medical issues, the entire care plan needed to be changed from active therapy to more supportive care. The second issue is that if I didn't even know my patient left hospital, and this happens time and time again, that patients actually do have a follow-up appointment booked with us, but in fact they show up and as family physicians we actually don't have any information from their hospital visit, so it's hard to coordinate what needs to happen if it doesn't actually get into primary care's hands. The other thing that we hear is I can't possibly keep track of all the resources to support patients in the community. And what we found in Central Lynn was that from many of our our top 1% and 5% who were using so much service, in fact, they weren't actually getting any CCAC support. They weren't getting they weren't getting care coordination support, and they definitely weren't getting in-home support. And that was interesting that these patients who are clearly high-cost users of the system weren't actually receiving support to keep them well at home. And then the last thing is really a practical matter, is how do I bill OHIP for participating in a Health Links case conference and CCAC supervision? Family physicians, as you heard from Dr. Charles, are quite busy, as are most physicians in the community. And if we're going to ask them to book off some time in their day, we need to do it in such a way that they're going to be remunerated for looking after their patients. The second issue is that of communication. And this is often from the acute care sector. We don't know who our family physicians are. I've done a lot of work in Arlin around trying to compile some of the things like cell phone numbers and back office phone numbers for our primary care providers. We actually lack an up-to-date directory of what primary care is happening in our local geographies. What we hear time and time again is that we can't get through directly to primary care providers. Hospitals say we can't book follow-up appointments because we can't actually get through to their secretaries, let alone speak to them about trying to book case conferences while the patient's still in hospital. And finally, it is very difficult. Everybody's busy, and it's hard to find a time for everybody to meet. I said primary care providers are busy, but we know in our system everybody really is busy. So if you go on to my next slide, I'm going to talk about some possible mitigations of these challenges, especially around community physician engagement. So the first thing is that we need to be able to explain to them, and sorry that my Mac slide got cut off here when it got converted to PowerPoint. We have to, when we speak to primary care and community specialists, we need to explain to them what does joining a health link translate into. What's the value proposition for a physician to want to be part of a health link? And really, I think it is asking them, how can we better help you look after your patients? And that's a very different message, I think, than most community-based physicians have heard from the acute care sector for the last, at least the last decade. And I just gave some sort of concrete examples around trying to improve their satisfaction, their patient satisfaction. We heard a lot about transitions in care from Dr. Charles, increased communication, and collaborate on quality improvement projects. Because at the end of the day, I think most of us want to do better, but we need the tools to help do better and look after our patients. So if you go to my next slide, what we created and what I suggest each of the health links do create is really an engagement plan for ongoing physician engagement over the next year as we roll out care coordination as part of the Ministry's Health Link initiative. And I've given a whole bunch of individual topics down the left side of this slide, but what I will do is actually give Health Quality Ontario a more detailed plan that I have. I just didn't want to share the details with you for time's sake, but that should be available on their website once they translate it into French, is what we've heard, for each of these individual ideas. But really liaising with a lot of existing resources like the Ontario Medical Association or the Ontario College of Family Physicians, who know how to engage family physicians in not necessarily in traditional CME or hospital-based rounds, supporting family physicians to implement Hospital Report Manager locally so that you can actually get those hospital reports into their electronic medical records. We heard from the Minister this morning that 75% of family doctors do have an EMR now, and it's really about how do we get the information into their EMR so that they can collaborate and communicate effectively. Start looking at warm handoff programs for our complex patients from our hospitals. Meet with chiefs of staff locally to get specialists on board. And really, a lot of it's going to be face-to-face engagement. Going to your local primary care groups to engage them in health links. Don't invite them, as Jonathan Kerr, who's the incoming OCFP president, says, don't invite them to your meeting. Ask that you can go to their meeting, because like we heard, they're quite busy. And then looking at a whole bunch of specialist, access to specialist initiatives. We've heard in Arlen time and time again that access to certain specialties, especially mental health, is an issue, and there's a lot of successful programs elsewhere in the country and in other jurisdictions that we should probably look at. Again, this is not about adding more resources, but to actually work a little smarter with the resources that we have. And so with that, I'm going to end, and we'll leave a few minutes to take some questions.
Thank you very much, Dr. Kaplan and Dr. Charles. Julie, we have a few minutes for questions. Do we have something there?
One is more an administrative question I just thought I'd address. People have been asking about the PowerPoint slides. They will be posted on HQO's website under the Best Path link, and they do require to be translated into French before we're permitted to post, so that will take some time, likely a week or so. A question it looks like for Dr. Charles is whether you're able to share more information about the Coordinated Care Plan, the version 12.
Anyone can have it. I'm happy to send it. You can post it on the HQO website if you want. But it will be, we will be doing exactly what Central Lynn is going to be doing, and that is we hope to be piloting the Ministry of Health Coordinated Care Plan template. We've been using the template that I've done while we've been waiting for the Ministry of Health. So I believe in having one template for all. But happy to share mine, or ours.
Thank you. Do you, just in follow-up to that, do you have an idea of the timeline for the provincial coordinated care plan?
I understand that the paper pilot is going to begin early in 2014, and I think we will find out a little more detail next week.
Thank you. So that's it for questions so far.
Okay, thank you. Just remind folks, we are almost out of time, but we have a few seconds here, and Dr. Charles and Dr. Kaplan, if you don't mind, just a few minutes. The way to ask questions, as Julie had shown earlier, to use the question box, and Julie's monitoring that. While you do that, I'm going to just show where you will be able to find the resources in the with regard to this webinar. It might be a week or so before they're posted, but you will find them there. This slide deck, of course, will be available, and this list, I'm not going to read it out, but there are some key resources that you can access. And again, the improvement packages, if you haven't looked at them, please do. They're a great resource. especially the one that we've spoken of today, the transitions of care. And we give a huge challenge. That we've heard lots of ideas today. Maybe some of you may have heard of the challenge, what can you do by next Tuesday? It's meant to be something that's easy and can be done quickly and easily. And Dr. Charles and Dr. Kaplan both gave examples of the patient engagement, including the patient. So encourage you trying that out. Julie, are there any more questions coming up?
No, that's it.
No, that's it. Well, thank you ever so much. Dr. Charles and Dr. Kaplan, thank you so much for taking the time out of what I know is your hugely busy schedules. And as you mentioned, this is you love your work because this is on top of your regular work, and thank you for that.
We do have one question coming.
Oh, okay, one question.
Okay, here we go. A question for Dr. Kaplan. How are you handling the issue of health links being geographically bound by postal codes, but have family practices that have patients from many geographies?
Did you hear that?
Yes, I did. Can you hear me okay now? So it's an excellent question. I actually have we have a meeting this Friday to discuss this, the cross-boundary issue. I deal with this on an ongoing basis because my practice is right on the 401. So I bound 2 LHINs, and I deal with 2 community care access centers all the time. We've had a lot of good discussion, and that's why we've done a lot of this work around trying to ensure that we're using the same templates as Toronto Central, because we know that our patients are going to show up elsewhere. And it's important that people are familiar with the tools that we've all agreed to use. We know, at least we're in my geography where we work, that if I make a referral for a patient who lives outside the geography, it does get forwarded to the appropriate health link. But for the time being, what we've decided in our local health link is that we're focusing on patients that are in our geography. If we identify complex patients that are at risk of readmission, we do refer them to their local CCAC for usual care. But that's an excellent question. I'm not sure what the answer, the best answer is, but in this sort of program phase and implementation phase of health, that's what we've decided to do.
And I think that we'll be successful if the patients don't know our boundaries.
Okay, thank you. Okay, I think we're just about out of time, and we are out of time. I just want to thank Julie Nichols at the table here and Judy Latreille out there, and Theo, who's been just amazing here in the office. Thank you to Sandy Seaman, who did some of the heavy lifting for some of the content in our slide deck. A reminder, please, folks, we have another webinar coming up in the series, December 5th, on medication reconciliation, and the guest speaker is Kim Tuana. There will be an email sent to you to gather your feedback, and we really, really appreciate your completing this. We really do study and act on this information to improve future webinars. We're interested in your email around what you want next around this particular topic. Thank you, folks, and have a great day. Bye for now.
It's weird. It shouldn't be a problem.